Hello, my name is Brad. I am a PGY1 pharmacy resident at Wake Forest Baptist Health, and this is my project evaluating a novel multiplex molecular panel in patients with hospital-acquired pneumonia. My team and I have nothing to disclose. Hospital-acquired pneumonia can be a severe and sometimes fatal infection. It accounts for up to 25% of all ICU infections, and the overall mortality rate attributed to HAP can be between 30 and 50%. Respiratory cultures are the standard method of pathogen identification. However, results may take up to 24 to 72 hours. The film array pneumonia panel, or FPP, is a multiplex PCR panel that identifies 18 bacteria, 8 viruses, and 7 antimicrobial resistance genes. It is a relatively expensive test, however. It evaluates tracheal aspirate and bronchoalveolar lavage samples within approximately 1 hour. Prior to implementing this test at our institution, we sought to identify the potential utility of the film array pneumonia panel in patients with HAP. Patients included in this study were greater than or equal to 18 years of age, were located in the medical, surgical, or trauma intensive care units, and had TA and BAL cultures obtained from November 1st of 2019 through February 29th of 2020. Patients were excluded if they did not meet clinical criteria for HAP as defined by IDSA guidelines. For our study, we identified TA and BAL specimens collected for routine culture and susceptibility reporting. We tested the specimens with the FPP based on our study targets. We then assessed for a diagnosis of HAP based on chart review, and no patient was included more than once. We then determined the potential clinical impact if the FPP results were known in real time. We performed a cost analysis, which was the sum of antibiotics and respiratory viral panels avoided minus the cost of the FPP per patient. We analyzed our data using descriptive statistics. Our target sample allocation is as follows. For positive respiratory cultures, we targeted 20 samples from the MICU, 15 from the SICU, and 10 from the TICU. For negative respiratory cultures, we targeted 5 samples from each the MICU, SICU, and TICU. Our primary outcomes included the instances where the FPP could have changed antimicrobials, in addition to the potential difference in time to optimize therapy. Our secondary endpoints included agreement of the test results, identification of patient populations where the results would have the highest impact, in addition to cost impact. When assessing clinical implications, we assumed the best case scenario for antimicrobial decision making. For example, if MRSA was not identified on the FPP, we assumed that the treating team could discontinue vancomycin. If an uncovered pathogen was identified, however, therapy could be expanded. We defined time to optimize therapy as the time of the final culture susceptibility report minus the time of the availability of the FPP result, which was the time of the sample collection plus 4 hours for logistical purposes. These are the respiratory samples tested minus patients excluded, so we included 56 patients for our final analysis. Our sample distribution is as follows. As you can see, we did not quite meet our total target sample allocation due to having a limited number of tests available. Our patient's mean age was 60.4. We had 70% males. The type of culture was predominantly tracheal aspirate with 82.1%, and 64% of our patients had a respiratory virus panel, or RVP, obtained, only of which 11% were positive. Of the 56 samples tested and evaluated, 44.6% of the time the film array pneumonia panel and respiratory culture agreed. 55.4% of the times, however, they disagreed. With this high number of disagreements, let's look at these in closer detail. Of the disagreements, in 48.2% of cases, the FPP identified additional pathogens. 5.4% of total cases were where the additional pathogen was clinically significant, where the patient's antimicrobial therapy in real time did not cover relevant pathogens. 12.5% of cases were where the respiratory culture identified additional pathogens. However, in all of these cases, The pathogen was not included in the FPP, therefore the test was not capable of picking up that pathogen. For our primary outcomes, we found that 64.3% of patients would have had a therapy change based on the results of the FPP. 60.7% of these were opportunities for narrowing of antibiotics, where vancomycin was the most common antibiotic that could be discontinued. In 5.3% of patients, however, there was a need for expanding of antibiotics. The potential difference in time to optimize therapy was 51 hours. And I would like to point out that this was normalized for the 36 patients where there could have been a difference. We had the most profound impact in the SICU and TICU patients. Our average antibiotic cost savings per patient would have been $60. The RVP cost avoidance per patient would have been $125. The cost of each FPP is $195, so in turn the increased cost per patient would be $10, which was normalized for the entire 56 patients. Our study was limited by the fact that it was a single center study. Evaluation of HAP was based on a retrospective evaluation of clinical documentation. The limited number of available tests prevented our target attainment, and our cost analysis did not include clinical outcomes such as length of stay in the ICU or hospital or adverse events. Lastly, we looked at WAC or wholesale acquisition costs instead of actual cost used for our final analysis. We concluded that the film array pneumonia panel would have prompted a change in therapy in about 2/3 of our patients studied. The potential benefits include quicker time to optimize therapy, reduced exposure to broad-spectrum antimicrobials, and reduced cost of broad-spectrum antimicrobials in addition to other rapid diagnostics, such as RVPs. The potential impact appeared to be greater in the SICU and in the TICU, and an analysis of the potential impact of novel diagnostic tests, such as the FPP, should be considered prior to implementation. I would like to thank my team for their hard work on this project. And last but not least, we have my assessment question, which is what is the potential utility of the film array pneumonia panel in patients with HAP? Overall, we found that there would be a quicker time to optimize therapy, there would be reduced exposure to broad-spectrum antimicrobials, and there would be a reduced cost of broad-spectrum antimicrobials and other rapid diagnostic tests. Thank you for attending my virtual presentation.